All right, so we're going to talk about the different types of neurotransmitters. We'll focus on acetylcholine, which is an important one, but also we're going to focus on norepinephrine. So norepinephrine is a new one we started talking about a little bit last week, and we can also call that one noradrenaline. So the autonomic nervous system, as we said, uses acetylcholine, ACH, and norepinephrine, or NE. And another name for norepinephrine, as I said, is noradrenaline. So you can think of adrenaline, it can also come from the adrenal glands, or adrenaline. And those are both catecholamines, the norepinephrine and epinephrine. And epinephrine, another name for that is adrenaline. So either neurotransmitter can cause stimulation or inhibition, depending on the receptor that's in that postsynaptic cell. So usually an effector is what we'll be talking about. So the skeletal muscle, the smooth muscle, or the gland. Acetylcholine is the one we talk about most. So where did we talk about acetylcholine? Did we go over neuromuscular junction, right? So the neuromuscular junction is going to be right in between the nerve and the muscle. And so we found that in the somatic nervous system. But we also have acetylcholine being used in the autonomic nervous system. And so our autonomic nervous system, as I said, is going to be a little bit more complicated than the somatic nervous system. And in this case, the autonomic nervous system is going to use acetylcholine. And some of these cells are going to use acetylcholine, and they're called cholinergic. So any neuron that releases acetylcholine is called a cholinergic neuron. So all of our motor neurons in the somatic nervous system are called cholinergic neurons. And so they're all of the preganglionic neurons also. So remember, the preganglionic neuron is the one that left the spinal cord and went to the ganglia. So that first one. So the first one that's myelinated, that one is going to release acetylcholine, just like the lower motor neurons of our somatic nervous system. In the parasympathetic nervous system, the whole parasympathetic nervous system uses acetylcholine. So all parasympathetic ganglionic neurons. So that's the second one. That's the second one that goes from the ganglion to the effector. So in the whole parasympathetic nervous system, the whole thing uses acetylcholine. So that one's easy to remember. And then there are a few types in the sympathetic nervous system. So sympathetic ganglionic neurons that innervate the sweat glands and the blood vessels in skeletal muscle. And so there's only a couple of them. The vast majority of the sympathetic nervous system, the ganglionic neurons, are going to use norepinephrine, and we'll get to that in a second. So whenever a cell releases acetylcholine, these cholinergic neurons release acetylcholine, it's going to go bind to a receptor. And these receptors we can call, and in the past we've called them acetylcholine receptors, but we can call them cholinergic receptors. So that means that they bind acetylcholine. So that's like the technical term. So a cholinergic receptor binds acetylcholine. And now we have two main types of cholinergic receptors, and they are called nicotinic and muscarinic. And we briefly talked about this in chapter 12, like that neurotransmitters and synapse chapter or section. So the nicotinic receptors are the ones that we are most familiar with. And if you went through that or have started that ANS worksheet, I know a couple of people turned it in, there are some questions about the different types of receptors, so this will help with that. So the nicotinic receptors are found on the neuromuscular junction. So if you think back to the neuromuscular junction, they're slightly different than the ones in the autonomic nervous system, but they're pretty much the same. Like there are subtypes. The ones in the neuromuscular junction are a little bit different, but they're all nicotinic. So they are the ones that are excitatory. When they open, sodium rushes in, and they're always excitatory. And they're found on the neuromuscular junction, and then a different subtype of them is found on all ganglionic neurons and the adrenal medulla cells. And so when acetylcholine binds the nicotinic receptor, it opens that cation channel. Sodium rushes in, a little bit of potassium moves out, but mainly we're interested in the sodium rushing in. And this causes the cell to depolarize, right? It's an excitatory postsynaptic potential. So nicotinic receptors are excitatory. They produce EPSPs, excitatory postsynaptic potentials. When we talk about different pharmaceuticals, so different drugs that can affect these effectors, one thing is important to know is that, as we said before, there are different subtypes of these nicotinic receptors, and the receptors at the neuromuscular junction are blocked by a drug called Curare. And so that's only going to get those nicotinic receptors at the neuromuscular junction, but it won't actually block the receptors on the ganglionic neurons. I'm sorry if you can hear my children yelling in the background. They're not happy. My husband is supervising downstairs. So the other subtype, this is the other big type of cholinergic receptors, are muscarinic receptors. And these are found in all target organs of the parasympathetic division and a few of the sympathetic division. So the nicotinic ones we found on the ganglion, in the ganglions, so in between the preganglionic and the ganglionic neuron, as well as in the adrenal medulla, whereas the muscarinic receptors are found at the effectors. So they're at the end of the effectors where that ganglionic neuron or the postganglionic axon is attaching. And so we said that the whole parasympathetic nervous system uses acetylcholine. And so these muscarinic receptors are found on the target organs or the effectors of the parasympathetic division. And remember, we said just a few sympathetic nervous system, just a few neurons use acetylcholine. But those neurons that use acetylcholine, there are muscarinic receptors on those effectors. And so the sympathetic effectors within the with muscarinic receptors are going to include sweat glands and the blood vessels and skeletal muscle. All muscarinic receptors use second messengers. So when we talked about a direct versus an indirect receptor in chapter 12, the nicotinic receptor is that direct receptor. It directly opens up a cation channel, and it's really simple. That's how depolarization happens. Sodium rushes in. That's what we've talked about a whole bunch. Whereas the muscarinic receptors are a little bit more complicated. They're going to bind to the receptor on the outside of the cell, and that's going to activate something else inside the cell. Many times it's going to be a G protein, or sometimes it can be something else, but it's going to cause a complicated cascade that's going to eventually cause a change in the cell. So in the endocrine system, chapter 17, we're going to talk about some different second messenger systems. But for now, just know that second messengers are more complicated, and we'll learn about them a little bit later. But basically, it can do a bunch of different things when that second messenger system. It can either be excitatory or inhibitory. So for example, when acetylcholine binds to muscarinic receptors of smooth muscle in the GI tract, it's stimulated to contract more. When acetylcholine binds to muscarinic receptors on cardiac muscle in the heart rate decreases. And so we have different effects that can happen at different organs based on these different subtypes of effectors. So here's this picture that kind of talks about the acetylcholine and the two different types of receptors. So acetylcholine is going to be released from the cholinergic neuron. It's going to go across the cleft, and it's going to either bind to the nicotinic receptor, which is a direct acting receptor, right? It lets sodium in and it causes an EPSP. And they're stimulated by nicotine, and the ones at the neuromuscular junction are inhibited by Curare. Whereas we have these muscarinic receptors, these are indirect. They're going to bind, and it's going to, instead of like opening up a channel that lets an ion in, it's going to cause a change in usually a G protein. It's going to cause a cascade of events that happens within the cell, and it can either cause an EPSP or an IPSP. And this one is an indirect acting, so it doesn't directly open that channel. So the other type of neurotransmitter that's used in the autonomic nervous system is norepinephrine. And so norepinephrine is a catecholamine. As we said, another name for it is noradrenaline. And it helps to remember that another name is noradrenaline, and then epinephrine is also known as adrenaline, because cells that release norepinephrine are called adrenergic neurons. So think adrenaline, like adrenergic neurons. And so most sympathetic ganglionic neurons are adrenergic. So of the two systems, the sympathetic is the only one that uses norepinephrine. And those target cells, most of the effectors, have adrenergic receptors. So an adrenergic receptor is like a norepinephrine receptor, and it's going to bind to both norepinephrine and epinephrine. So we talked a little bit about the different classes of neurotransmitters back in chapter 12. Norepinephrine is a catecholamine. Catecholamines are a chemical subtype of the biogenic amines, right? And the biogenic amines are one of those 4 different types of neurotransmitters. They are ligands, like little chemicals that bind to the membrane receptors. Norepinephrine, also known as noradrenaline, and epinephrine, also known as adrenaline, are both catecholamines that bind to adrenergic receptors, right? So that makes more sense now why we call them adrenergic receptors, because they bind to adrenaline. And that adrenaline comes from the adrenal medulla, right? Or can also come from the adrenal medulla. So the 2 main types of adrenergic receptors are alpha and beta receptors. And so this is a bit of an oversimplification, but you can think of cells with alpha receptors are typically stimulated by norepinephrine, whereas cells with beta receptors may be stimulated or inhibited by norepinephrine. But it's a lot more complicated than that. We have different subtypes of each of these receptors. And so these receptors here, so our alpha receptors, we have both alpha 1 and alpha 2 receptors. And so alpha 1 receptors are going to be stimulatory receptors. They're found on most smooth muscles. These are located in most blood vessels, like most of the blood vessels in our body. The erector pili muscles that connect to our hair in our skin, the uterus, which promotes contraction, the ureters, the internal urethral sphincter, which closes it, and the dilator pupil muscle, which dilates it. Alpha 2 receptors are located throughout the brain, the CNS, in the pancreas. They inhibit insulin secretion, and in the GI tract sphincters, they cause it to them to constrict. So we can kind of see like things like we're constricting the GI sphincters and we're inhibiting insulin release. We're kind of decreasing some of our GI stuff, because most of these alpha receptors, right? Remember that norepinephrine is only used by the sympathetic nervous system. Next, we have our beta receptors, and we have 3 primary types of beta receptors. So beta 1 receptors, beta 2 receptors, and beta 3 receptors. So beta 1 receptors are primarily stimulatory, and they're located in the heart, right? So remember, this is all of this is happening, this is in the sympathetic nervous system. So these beta 1 receptors are located in the heart, and they increase the heart rate and the force of contraction, right? So remember that one of the things that the sympathetic nervous system does is it increases the heart rate and the force of contraction. They're located in the kidney, and they stimulate renin secretion, and we'll learn about renin secretion in the kidney and endocrine chapters, so you don't have to worry about that too much, but it's a hormone. Beta 2 receptors are primarily inhibitory. These are located in the smooth muscle vessels to the heart, the liver, and the skeletal muscle. They cause vessel dilation. They're located in the lung, which causes bronchodilation. They're located in the uterus and the GI tract smooth muscle, which causes relaxation, right? So we're relaxing the GI tract, so we don't want it to be doing too much during this fight or flight response. We're opening up the muscles in the heart and the skeletal muscle. We're dilating those. And we're relaxing the detrusor muscle of the bladder. And then finally, we have beta 3 receptors, which can be stimulatory or sometimes inhibitory, right? It's kind of confusing. It depends on exactly where they're located. So if you do end up looking more into this eventually, you'll just have to learn exactly where each subtype is located. So these are located in adipose tissue, the urinary, and the urinary bladder for smooth muscle relaxation. And so some types of tissues, right, might have a few different types of receptors. So now we're going to look, your book also has a whole chart of these. And so on that chart, it also has an area that says like pharmaceuticals and where the pharmaceuticals work. So if anyone's heard of a beta blocker, right? So these are the beta receptors. Beta blockers block beta receptors. And so a beta blocker, you might use that for like high blood pressure, and we use a beta blocker to kind of lower our blood pressure. So it's going to block these like this one, beta 1, right? It's going to block these beta receptors. And normally the beta receptors would make the heart rate and force of contraction increase, which would therefore increase the blood pressure. But if we take a beta blocker, we're going to block these receptors. So we're going to block the increase in heart rate and force of contraction. So that's going to lower the heart rate and force of contraction and thereby lower the blood pressure. And so these receptors here are a good area that we can target drugs, and we can target drugs to kind of, we can either block those, like a blocking, or we can give an agonist. An agonist means that it's going to bind to the receptor and cause the effect, whereas an antagonist means it's going to bind to the receptor and block it. So there's a couple of different things that we can do with drugs, like pharmaceutically, to affect these receptors. So it's kind of good to know a little bit about them and what they do and where they're located. So this is a really good chart here. And your concept overview pictures that we talked about last time, it had these pictures on it, were the parasympathetic and the sympathetic ones. And I said, we'll talk more about it next week because we're talking about the different. Sorry, real quick. Asana asked in chat, do we need to learn the location and functions of each of the adrenergic receptors? So let's see, for these guys here, I would know that the beta-1 receptors are located in the heart, and they increase the heart rate and force of contraction. That's kind of a big one because we talked about that with beta blockers. We're going to talk about a clinical view of the beta-2 receptors in a little bit that has to do with bronchodilation and asthma. So since we're going to talk about that clinical view, I would definitely talk about those. So beta-2 receptors are going to be, they are in the lung and they cause bronchodilation, just because these are the examples that I've used before. Those are the main two that I'll probably ask about, since any of them that I give specific examples about would be the ones to remember. All right, so comparison of neurotransmitters. So parasympathetic is the easiest, right? There's only one right here. So with our parasympathetic pathway, we have our preganglionic axon here, and this is going to go to a ganglion. So imagine that this right here is a circle. This is a ganglion, and it's going to release acetylcholine. And if you notice, all of these preganglionic axons, so all of the brown axons here that are preganglionic, they all release acetylcholine. And that acetylcholine, so they're all cholinergic. That acetylcholine is going to go to nicotinic receptors. So they all have, so the ganglionic neurons all have nicotinic receptors on them. And these are all excitatory, right? So they're going to excite the next one. And then in this case, remember that the adrenal medulla pathway is the only pathway that doesn't synapse at a ganglion. It goes straight to the effector. So in this case, it's still going to be a cholinergic neuron, and it releases acetylcholine, and the adrenal medulla cells have nicotinic receptors on them. So it's still the same. The first one here is releasing acetylcholine, and there's a nicotinic receptor. So that's a good one to know. So all of these preganglionic axons, they're all cholinergic. They release acetylcholine, and then the ganglionic neurons or this effector, they all have nicotinic receptors here. And so we start with a cholinergic neuron, and at the ganglion or the adrenal medulla, it releases acetylcholine, and then we have nicotinic receptors. Now, this is where we get a couple of different things, where we get some differences. So in the whole parasympathetic nervous system, the ganglionic neuron is also cholinergic, and it releases acetylcholine. And the target cells are going to have muscarinic receptors. And there are different subtypes of muscarinic receptors. And so it can either be excitatory or inhibitory depending on, where it's found. So that is parasympathetic. So we start with a cholinergic neuron. It releases acetylcholine to nicotinic receptors. And then the ganglionic neuron is also cholinergic. It releases acetylcholine to muscarinic receptors at the target cell. So parasympathetic is simple because there's only one option. Now we get to the sympathetic pathways, and this gets a little more complicated. So remember, we said that the preganglionic neuron is always cholinergic, and it always releases acetylcholine, and that is always going to have a nicotinic receptor, right? So either at the ganglionic neuron or at the adrenal medulla. So we've already kind of talked about this pathway here. Now here are the other two pathways. So the vast majority, this middle one right here, this is the vast majority of the sympathetic nervous system. So the vast majority of the sympathetic nervous system is going to have a ganglionic neuron then that is an adrenergic neuron, meaning that it releases norepinephrine or noradrenaline, right? And so that noradrenaline, norepinephrine, is then going to go to an adrenergic receptors. And so it could be alpha 1, alpha 2, beta 1, beta 2, beta 3, just depending on the different types. So this right here is the most common. So there's only one instance where this happens, right? It goes to the adrenal medulla cells. In this sympathetic pathway here, this is the vast majority of our sympathetic nervous system uses norepinephrine. And then just a few little places. So like the sweat glands, like just a few places, not many at all. This is the exception and not the rule. We will have, it's similar to the parasympathetic nervous system where the ganglionic is also cholinergic and the target cells have muscarinic receptors. But this is the exception to the rule. It's not common. The vast majority of our sympathetic pathways are going to be like this middle one here. They're going to use norepinephrine, and then those are going to bind to adrenergic receptors, you know, one of those 5 different subtypes of adrenergic receptors. So as we said, that I was going to talk about some beta 2 receptors for our clinical view. And so this is epinephrine as treatment for asthma. And remember, the other name for epinephrine is like adrenaline. And so asthma attacks narrow the bronchioles. And the bronchioles are these little, you know, openings, these tubes inside the lungs. So when they narrow them, they constrict. It's really hard for people who have asthma to breathe out, right, to exhale. Bronchioles contain beta 2 receptors. And when those beta 2 receptors are stimulated, it causes them to relax. And so what we really want to do is we want that to happen. We want those bronchioles to relax so that enough air can get into and out of the lungs, right? So that our person with the asthma attack can start breathing. So your body probably has some norepinephrine going to those beta 2 receptors, but it's obviously not being effective enough. And so epinephrine is actually, it binds to beta 2 receptors even more effectively than does norepinephrine. So remember, they're both catecholamines and they both can bind to those adrenergic receptors. So we can use epinephrine as a treatment. So you think of an EpiPen, right? So we can use epinephrine as a treatment to treat asthma attacks because it's a more potent, which means that it's more effective. It does a better job at relaxing the smooth muscles in the bronchioles. So it causes more dilation. And so this one, epinephrine, is like a beta 2 agonist, meaning it's going to bind to that beta 2 receptor and activate it and cause, you know, and cause the action that normally happens to happen. So epinephrine is going to bind to the beta 2 receptors and cause it to relax because that's what they normally do. So relaxation in the bronchioles. And so the ability to kind of know where these receptors are and what they do, and then which drugs affect them, can be really useful. And it can be really helpful to understanding why different drugs have different effects. All right. So the next thing I want to talk about is innervation of our body with our 2 different systems of parasympathetic versus sympathetic. So how like I know we have these 2 different systems, but how do they work together? And so autonomic plexuses, remember we said plexuses are networks of these interweaving nerves, right? And so these autonomic plexuses are going to be networks of nerves within the thoracic and abdominopelvic cavities. And they're going to contain the sympathetic postganglionic axons, remember, because those postganglionic axons are a lot longer, and parasympathetic preganglionic axons, because the parasympathetic nervous system has long preganglionic axons. And then we also have some visceral sensory axons, right? Because we do have both the autonomic nervous systems, right? Sympathetic and parasympathetic are motor. So we do need some sensory input also from those vessels. So the two really important ones that we'll mention are the cardiac plexus and the pulmonary plexus. And I'm not going to have you kind of learn all of them right now. As we go through the different body systems in 169, we'll kind of talk about the different nerves that are affected with each body system. But the cardiac ones and the pulmonary ones are pretty important for the lungs and the heart. And so the cardiac plexus includes sympathetic axons from the cervical and thoracic trunk that quickens the heart rate, as well as parasympathetic axons from the vagus nerve that slows the heart rate. Right, so they work in opposition to each other. So sympathetic is going to increase the heart rate, parasympathetic decreases the heart rate, and this way we can easily, well, maybe not easily, but our body can monitor the heart rate and increase it or decrease it as it needs, right? So we can easily sort of make your heart rate faster or slower as needed. Your pulmonary plexus is next, right? Pulmonary means lungs. This includes sympathetic axons from the cervical and thoracic trunk again, which cause bronchodilation, right? Remember we said those beta 2 receptors are going to be there. They're adrenergic receptors. They cause bronchodilation. And then parasympathetic axons from the vagus nerve, which cause bronchoconstriction. So once again, we see an example of them working sort of against each other, but this way we have a way for that negative feedback mechanism to maintain homeostasis. So we can see here the cardiac plexus is going to be up here, the pulmonary plexus is down here. We also do have some other plexuses within the abdomen, but at this point, I'm not going to have you guys memorize exactly what the plexuses are and what they do, but I do want you to know what the general functions of each system are on all the organ systems. Now, I do want to mention, though, that there is something called an enteric nervous system. And we're going to talk about this more in 169, but I want to mention it here so that you've heard about it. So the enteric nervous system is the autonomic motor and visceral sensory neurons that are arranged throughout the wall of the GI tract. So it's almost like the GI tract has its own little nervous system. That's what enteric nervous system means. That innervates the smooth muscle of the GI tract and the glands, and it helps coordinate peristalsis so that your GI tract kind of can work and coordinate its own peristalsis so that the rest of your you don't have to consciously think about it. And it includes two large plexuses, the submucosal plexus, which is going to be in the submucosal layer of your GI tract, and the myenteric plexus, which is in the smooth muscle layer of your GI tract. And we'll mention this and see examples of it in our digestive tract lectures in 169. So these two systems, the parasympathetic and sympathetic nervous system, are going to be working together. And they're working together to maintain homeostasis at all times. And so most of our effectors, right? Remember, effectors are skeletal muscle, not skeletal, cardiac muscle, like our heart, smooth muscle that lines our organs, as well as glands, right? So our endocrine glands. Most of them are innervated by both divisions of the autonomic nervous system. And they both continuously release neurotransmitter. And we call this autonomic tone. Usually, we have a little bit more parasympathetic tone or vagal tone, because remember that the vagus nerve is parasympathetic. And so if you hear someone say, oh, there's high vagal tone, that means it's high parasympathetic tone. And that just means that our parasympathetic nervous system generally wins out a little bit. We would rather that our resting state be rest and digest, and that the sympathetic nervous system only wins when we have some sort of excitement. We don't want to be stressed out all the time. So hopefully our parasympathetic nervous system kind of wins out more often, so we're resting and digesting more often. There are some cases where the effectors are only controlled by the sympathetic nervous system. And so it's usually, so the sympathetic nervous system is a little bit more widespread than the parasympathetic nervous system, and so it's more likely that the sympathetic nervous system is going to control the status of an effector, so our blood vessels. And so our blood vessels are only going to be controlled by the sympathetic nervous system. So they're usually kind of partially constricted due to sympathetic tone. Excuse me. And so this is called vasomotor tone. The vessel will constrict if sympathetic activity increases, and the vessel dilates if sympathetic activity decreases. And so, as I said before, your heart is going to be innervated by both divisions of the ANS. So they're both continuously releasing neurotransmitter. So your heart is kind of, it has sympathetic and parasympathetic tone all the time. Our vagal tone, right, which is parasympathetic tone, is going to continuously decrease the heart rate because, as we said, we want to be resting more often. And so we don't always want to have our heart rate up really high as if we're exercising. So if you hear the term vagal tone, it means more like parasympathetic tone because the vagus is a parasympathetic nerve, right? Cranial sacral. It's a cranial nerve. So dual innervation is where the organ receives input from both the sympathetic and parasympathetic divisions. As we said, this is more common, and most of our organs are dually innervated. And the two divisions may either be antagonistic or cooperative. And so the vast majority of them are antagonistic, and that's what we've talked about. So the two divisions oppose each other. So a couple of good examples with control of the heart rate. Parasympathetic activity slows the heart rate, whereas sympathetic activity increases the heart rate, right? So once again, this allows us to maintain homeostasis, to maintain that set point. And the cardiac cells have both cholinergic and adrenergic receptors so that they can respond to both neurotransmitters from both systems. So if we look at the GI tract, it's the muscles in the GI tract. Parasympathetic activity increases the GI tract motility, right? Because parasympathetic is rest and digest. So we're digesting. We need our GI tract to be, churning and undergoing peristalsis and digesting our food. Whereas sympathetic activity decreases motility, right? If we're being chased by a saber-toothed tiger, we don't really need to worry about digesting our lunch until, after we've escaped. And so once again, the GI smooth muscle cells have both types of receptors, so they can respond to both types of neurotransmitter and both types of both systems. So our pupil, right, control of the pupil in your eye here, the parasympathetic activity decreases pupil diameter, so it causes it to constrict, whereas sympathetic activity dilates the pupil. And the way I remember this is I think about dilating the pupil as letting in more light so you can see really well, and maybe in a very fight or flight instance, you might need to see better. That's just a way that I can remember it, not necessarily why it happens. And so the parasympathetic fibers are going to innervate the circular iris muscles. So they actually innervate different muscles because one causes constriction and the other causes dilation, whereas the sympathetic fibers innervate the radial iris muscles. And we'll briefly talk about the different types of muscles in the in lab. So now rarely these two things have cooperative effects. And cooperative effects are when the parasympathetic and sympathetic stimulation have different effects that are part of an overall response. And a really good example of this is male sexual function. So penis erection is due to parasympathetic activity, whereas ejaculation is due to sympathetic activity. And so we need to have both of those kind of together, working together for this overall response. But it's a little bit more common for them to have antagonistic effects, as you could see by the many more examples we had. But as we said, there are some systems that are controlled only by the sympathetic division, because the sympathetic division is a little bit more widespread and it's going to control a couple of more things than parasympathetic. And so the blood vessels are one, and make sure you know this, the blood vessels are only controlled by the sympathetic nervous system. With increased sympathetic tone or activity, they're going to constrict. With decreased sympathetic activity, they're going to dilate. And this is most blood vessels, like the blood vessels to your GI tract and the blood vessels. These blood vessels can get a little confusing because remember, the sympathetic nervous system is going to innervate different blood vessels differently. So most of the blood vessels in our body, when we get excited, like when we're fighting or flighting, fighting or thinking about running away, we're going to constrict most of our blood vessels in the body. And so that's why increased sympathetic tone is going to constrict those. But there are a few blood vessels that are different. So the blood vessels to the skeletal muscles and the blood vessels to the heart are going to dilate because they have a different receptor. Examples of effectors innervated by only the sympathetic division would be the sweat glands in the trunk, the erector pili muscles in the trunk, and the adrenal medulla neurosecretory cells, as well as those blood vessels. Another clinical view is Raynaud's syndrome, and this is sudden constriction of the small arteries of the digits, right? So remember that our sympathetic nervous system is going to be important with causing constriction of our arteries. And these digits here are going to be just like part of the normal, the rest of they're not going to the skeletal muscle, they're not going to the heart, so they're going to constrict in response to that sympathetic nervous system. And this results in loss of normal hue of the distal skin. It just means that your fingers get really white. And it's usually painful because it's kind of like a spasm. It can be triggered by cold or emotional stress. And this is due to exaggerated local sympathetic response, and it's more common in women. And so exaggerated like constriction of those blood vessels. So the last thing we're going to talk about today is going to be autonomic reflexes. So if you remember back to last chapter, we talked about a reflex arc, right? And we looked at the spinal cord and we said, you know, the motor, the sensory portion and the motor portion and how the reflex arc is going to happen. So we're going to do the same thing, but we're going to talk about autonomic reflexes. So when we categorized reflexes last time, you know, we were in the spinal cord, so they were all spinal, and they were all talking about the skeletal muscle, so they were all somatic. Well, in this case, we have a couple of other reflexes, and they're not necessarily going to be spinal, and considering this is the autonomic nervous system, they're not going to be somatic. So we're going to talk about autonomic reflexes this time. And once again, as a reminder, the autonomic reflexes are pre-programmed. And once we have a stimulus, they have a pre-programmed response that's always the same. And this is usually a survival mechanism, or, you know, something that's important for homeostasis or survival. The arc is going to include a receptor, so that's going to be, you know, some receptor out in the peripheral nervous system usually. It's going to then have the sensory nerve relays the information to the central nervous system, which could be the brainstem or the spinal cord, depending on where the reflex center is. Then the CNS integration center, as we said, is either the brainstem or the spinal cord, depending on where it is. Then that integration center is going to, it has that pre-programmed response there. So that pre-programmed response is then going to be sent out down the motor neuron to the effector, which in this case, because it's an autonomic reflex, is going to be either a cardiac muscle, a smooth muscle, or a gland. So the first one we'll talk about is blood pressure. And remember that our autonomic nervous system is very concerned with maintaining homeostasis, right? That's an important survival mechanism because we need to maintain homeostasis in order to survive. So the cardiovascular reflex has to do with blood pressure. And so there are stretch receptors in our blood vessel walls. So think about if we have our blood vessel walls, if they're getting like extra stretched. Do you think there's high blood pressure or low blood pressure? There's high blood pressure, right? So higher blood pressure is going to stretch the vessel walls. It's going to stretch them like this. And that's going to activate those stretch receptors. And the special name for a stretch receptor is a baroreceptor. And so these stretch receptors respond to pressure elevation, right? So we have high blood pressure. It's going to cause those stretch receptors to stretch. And that's going to send that signal to the cardiac center in the medulla oblongata. So remember, in chapter 13, we talked about the brainstem, and the medulla oblongata is the lowest part of the brainstem, and it has all those autonomic reflex centers. So one of them is the cardiac center. And so it's going to go to the cardiac center, and then we're going to have this pre-programmed response. Like if our blood pressure is too high, right, we're going to inhibit the sympathetic nervous system and activate the parasympathetic output to the heart. So if we think about it, what does the sympathetic nervous system do to heart rate? It increases. What does it do to the heart's force of contraction? It increases. So we're inhibiting that. So we're making it so that it doesn't beat as fast and it doesn't beat as hard. And at the same time, we're activating the parasympathetic output. What does parasympathetic output do to the heart? It decreases the heart rate. It doesn't do anything to the force of contraction, but it decreases the heart rate. So we're going to be decreasing the heart rate. And because we're inhibiting that sympathetic, we're also decreasing the force of contraction, and therefore how much blood is ejected each time. And this decreases the blood pressure. Now, I wouldn't worry too much if that got a little bit confusing, because we have like 3 entire cardiovascular chapters where we'll talk about that in 169. Well, I guess really heart and blood vessels, so it's mostly 2 different chapters, but it does get more complicated than this, but this is the basic. And if we learn this first, it'll be easier. If we remember this when we go to 169, it'll be easier to pick up. And now the other 2 that we'll talk about, so this one, sorry, let's categorize this reflex here. So this reflex is going to the cardiac center in the medulla oblongata. So is it cranial or spinal? So it's up in the brain, right? So it's more cranial, right? It's going to go to the brainstem. It's not a spinal reflex here. And it's going to the cardiac muscle. So it's going to be a somatic response. Or excuse me, is it somatic? No, it's not somatic. It's autonomic. It's cardiac muscle, so it's going to be autonomic. So it's an autonomic reflex, and it's going to the medulla, so it's going to be more cardiac. So these 2 here The gastrointestinal reflex and the micturition reflex are going to go to the spinal cord. So both of these are spinal reflexes, but because they are going to smooth muscle, they're going to be autonomic reflexes. So I'm going to start with, we can talk about the gastrointestinal reflex briefly, and then we'll go to the micturition reflex. Both of these reflexes we're going to talk about, as well as the cardiovascular one, we're going to talk about in more detail in 169. But so the gastrointestinal reflex for defecation, once again, it's all about stretch receptors. We have a lot of stretch receptors in our visceral sensory receptors. So our stretch receptors in the rectum are going to respond to stretch by fecal matter. So when our rectum gets full of poop, we're going to get stretched out, and it's going to send information up to our spinal cord. Our spinal cord is then going to have that pre-programmed response, and it's going to go to the motor neurons, and the motor neurons are going to stimulate the rectum to contract and the internal anal sphincter to relax, right, to kind of stimulate defecation. And so both of those are going to be smooth muscles. So this is going to be a spinal reflex, and since they're smooth muscles, it's an autonomic reflex. Next, we have the micturition reflex, and this one is going to be the one we have a nice picture of, so I'm going to go to there. So the micturition reflex is another name for the urination reflex. And so in this case, we have our urinary bladder, right? And this is a prostate here, so this is a male. And so here's our urinary bladder, and it gets full of urine. And so once it gets to a certain point, it's going to start stretching that bladder. So we have those same stretch receptors, the baroreceptors, that are going to send signals. They're going to go up here, up the dorsal horn or posterior root to the posterior horn. And so these are visceral sensory receptors. They're going to go to an interneuron here. So this is a polysynaptic reflex, right? Because we have an interneuron and we have two synapses. And we have this pre-programmed response here. And the pre-programmed response is going to be to say, hey, our bladder is getting really full. We should probably empty it. And so we're going to send this information down here. It's going to the pelvic splanchnic nerves. This is a parasympathetic. And we'll talk a lot more about this in the urination chapter. But this is parasympathetic, right? So we have this long preganglionic nerve and these intramural ganglia here. And so it's going to go to the bladder. And it's going to tell the bladder that the detrusor muscle is the muscle of the bladder. It's going to cause that to constrict, and it's going to tell the internal anal sphincter to relax. Now, obviously, for both defecation and urination, we have conscious control. So we've got conscious control of the external urethral sphincter, and we have conscious control of the external anal sphincter. So we can kind of override these reflexes for a period of time so that we're not urinating and defecating in inappropriate places. I have young children. We're working on potty training, so obviously that's not inborn, but eventually you will be able to control those reflexes.